You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 27th, 2024. This week, we'll discuss surgical clearance, nonischemic cardiomyopathy assessment, dueling perspectives on PCI as first-line therapy for angina, and GDMT in heart failure with reduced ejection fraction. JACC has published a lengthy guideline document on perioperative management for non-cardiac surgery. And I'd like to say a few words on this because it comes up nearly every day. We are asked, at least in our clinic, to provide, quote, surgical clearance for one of our patients. This phrase, surgical clearance, may be the most ridiculous phrase in all of modern medicine. I would never write this, nor do I say it to anyone, but I think to myself, only God can clear someone for surgery. The notion inherent in the surgical clearance phrase is so preposterous that anyone who utters it ought to wear a sign saying that that person is a soft thinker. I mean, it is as if the requester of clearance thinks that a cardiologist will render the patient free of complications. And indeed, their patient may have no complications after surgery, but it is hardly due to anything that the cardiologist did. Listeners outside the U.S. may not have such problems of pre-op clearance, but we here in the U.S. waste a lot of money evaluating people before surgery. The guideline document, like all such documents, is massive and it's well referenced. One small suggestion that I would have is to make a section or table of RCTs in this space. This would make it easier for a user to know when an RCT versus observational data supports a recommendation. This particular document is nearly all observational data. A couple of specific comments on the document and, of course, perioperative management. This is a quote from the paper. Quote, stress testing should be performed judiciously in patients undergoing non-cardiac surgery, especially those at lower risk, and only in patients in whom testing would be appropriate independent of planned surgery. The authors only have two recommendations on stress testing. One is a 2B level of evidence, B with non-randomized studies. That's observational studies only. This is for patients with poor functional capacity and high peri-op risk. Stress testing may be considered to evaluate for ischemia. But the authors also write in the accompanying text that, quote, the goal of preoperative testing for ischemia is not to identify undiagnosed CAD, but to identify patients for whom revascularization is believed to improve clinical outcomes. And that's a pretty small group. Specifically, they write those with left main disease or severe multivessel disease with the reduced ejection fraction. Although that latter category, given Stitch and revived BCIS, is very much in question. The authors cited, right after that sentence, an observational study finding that centers with high levels of stress testing before abdominal aortic aneurysm repair had no better outcomes than centers with low stress testing. Of course, that's true. The value of routine stress testing before AAA repair should be reconsidered, and stress testing should be used more selectively given these findings and the associated cost of widespread testing, they write. The authors also write, quote, however, an abnormal stress test should not prompt coronary angiography or revascularization unless the study has high-risk features. And this statement goes back to the classic RCT called CARP. This was by McFalls et al. In New England Journal of Medicine in 2004, and I will link to it. This was a very strong trial, 6,000 patients with significant coronary disease who went on to have major vascular surgery. Revascularization versus no revascularization before surgery, and there were 0 differences in mortality, except the revascularization group had a 36-hour delay before surgery. The second thing the authors said about stress testing is that they give a class 3 no benefit for stress testing in patients who are at low risk for perioperative cardiovascular events or have adequate functional capacity with stable symptoms or who are undergoing low-risk procedures, and they write, routine stress testing before non-cardiac surgery is not recommended due to lack of benefit. Good. I love that statement, because stress tests are highly used in the U.S. Another specific comment on the matter of risk scores. First, I had no idea there were like 7 risk scores. I clear at least 1 to 2 patients for surgery a day, and I have never needed a risk score. Here is why. If the patient is not having cardiac symptoms, there is no need for testing, surely no need for revascularization. If a surgeon recommends surgery, I assume that that surgeon knows what they are doing. So I let the patient have surgery and attach a note saying that the patient has no modifiable risk factors that need to be done before surgery. There are 2 situations where I speak with the surgeon on the phone. One is if the patient is high risk to interrupt oral anticoagulation, and I see that a lot because we treat atrial fibrillation. Say the patient has prior stroke or an isolated left atrial appendage or a mechanical valve. I ask the surgeon, hey, are you sure surgery is required or highly beneficial, or can you do it without interrupting anticoagulation? Now, obviously, brain and bone surgeons need to interrupt anticoagulation, but I've been surprised that a lot of surgeons will do surgery without anticoagulation interruption if they're informed about the risk. Now, the second reason I speak with surgeons is when the patient is super sick, usually nearing end of life. You don't need a risk score for this. I say in a gentle way that this patient has days to weeks or weeks to months. Are you sure surgery would be helpful? Now, nearly every other case of cardiac disease, and I don't deal with congenital heart disease, can make it through surgery. If a surgeon says they have to have it, then I say, okay, we do it. Now, another comment about risk scores. If a risk score tells me that the perioperative risk is 12% versus 20%, does that really matter? No, it doesn't matter. People, not even me, doctors, can put these numbers into context. By the way, this is why CAC doesn't help statin decisions much. For example, can a factory worker or a carpenter or anybody tell the difference in risk between 7% and 12% over a future 10-year period? The answer is no. Most people can't. Another comment about the paper. There is a section on operating on patients with LVADs. I don't understand this. I would say A, don't operate on these patients. And B, if surgery is that necessary, you should be surely doing it at a heart failure center and make sure the LVAD team is there with you. With those caveats aside, the document contains a lot of practical information about specific scenarios. For instance, there is a table on handling DOAC interruptions. It's a really nice table, though all one really needs to handle DOACs perioperatively is an understanding of pharmacology, which any prescriber should have. The authors are also conservative about bridging with heparin, which is good because I think bridging with heparin is way overdone. There are comments in the paper on holding GLP-1 agonists for days before anesthesia due to delayed gastric emptying, and that is surely a new problem and an important problem. And it's not a small thing for these patients who require urgent surgery. So there's a message there, isn't there? All medical interventions have potential downsides. You know, like stable CAD patient who gets a kissing stent in a bifurcation lesion and then has to hold antiplatelets for spine surgery a year after the PCI. Medical interventions, even GLP-1 agonist or PCI, are not risk-free. Now, I'd love to hear from you all on the perioperative management comments. Am I doing it wrong by not using risk scores and pretty much clearing everybody without doing any testing? All right, next topic, nonischemic cardiomyopathy. We may be doing it wrong in selecting ICDs. I've spoken often on this podcast about the negative trials of ICD use in patients with nonischemic cardiomyopathy. The Danish trial was the most recent, but recall that the definite trial, which was also negative, as was the nonischemic subgroup in SCUD-HEFT. The thing is that all these studies, in fact, every single trial for ICD use in primary prevention uses left ventricular ejection fraction as the risk stratifier. Left ventricular ejection fraction of 34% and an ICD is indicated. Left ventricular ejection fraction 36% and ICD use is fraud. I say it this way to emphasize the folly of arbitrary EF cutoffs. But there is another problem with LVEF as the main risk indicator, and that is it's pretty lousy. While low EF confers a higher relative risk for VF and cardiac arrest, most events actually occur in patients with higher EF in the non-ICD eligible range, just in absolute terms. So back when ICD trials were done, left ventricular ejection fraction is all that we had. But times have changed. We now use cardiac magnetic resonance imaging, or CMR. CMR allows for all that an echo can do, like EF and valvular function, but CMR allows us to characterize tissue. Late gadolinium enhancement, or LGE, represents the reference standard for non-invasive assessment of focal replacement fibrosis, SCAR. While CMR offers other ways to characterize tissue, I'm not an imager and will focus mainly on the role of LGE, or SCAR, in risk prediction. SCAR in the myocardium sets up the milieu for arrhythmogenesis because reentry requires three things. Remember from medical school, two pathways, slowed conduction in one, and unidirectional block. That's reentry. SCAR provides that area. JAMA has published a comprehensive meta-analysis of studies looking at risk stratification in nonischemic dilated cardiomyopathy using CMR imaging. The first author is Christian Eichhorn. Meta-analysis, of course, have their limits, but this one I think is pretty useful because there are so many papers describing LGE and future risk in patients with this condition, nonischemic cardiomyopathy. Eichhorn's team found 103 studies, including 30,000 patients with nonischemic dilated cardiomyopathy. Many of these studies were single-center reports, only half were prospective. The mean duration of follow-up 3 years, and these were, of course, young patients at age 55, and a mean ejection fraction was 30%. Their main outcome measure was all-cause death, but they also looked at CV death, arrhythmic events, heart failure, and MACE, or major adverse cardiac events. The results: there were 96 of the 102 studies reported on the association between LGE presence and clinical outcomes, and in general, LGE presence is bad. The hazard ratio for death was 1.81, or 81% higher. For cardiovascular death, 2.43. For arrhythmic events, 2.69. So LGE confers higher risk. The extent of LGE also predicted events, and when the authors graded it per 1% higher LGE extent, the hazard ratio for all-cause mortality goes up by 7%, for cardiovascular mortality by 15%, for arrhythmic events 7%. Interesting is that when the authors looked at per left ventricular ejection fraction improvement, they found no significant association with all-cause cardiovascular death, rhythmic events. They did see slightly lower hazard ratios for heart failure and MACE per 1% higher ejection fraction. And they found not enough data to comment on ECV or T1 relaxation times or global longitudinal strain. They did a meta-regression, and they found that the association between LGE presence and all-cause mortality was significantly modified by three things: patient age, gender, and baseline ejection fraction. And they found these stronger associations were seen in younger patients, those with more severely impaired systolic function, and higher proportions of male participants. Interesting was that the baseline left ventricular ejection fraction did not modify the association between LGE presence, and cardiovascular mortality, arrhythmic events, heart failure events, and MACE. So the conclusions of the authors of this meta-analysis was, quote, the presence and extent of LGE were associated with various adverse clinical outcomes, whereas LVEF was not significantly associated with mortality and arrhythmic endpoints in non-ischemic dilated cardiomyopathy. Risk stratification using native T1 relaxation times or extracellular volume fraction and global longitudinal strain require further evaluation. So my comments. Now look, I am not an imager, so I must admit some weakness in imaging, so I'm going to tread carefully. But it seems clear to me that times are changing. This comprehensive view makes it clear that the presence and extent of LGE is a clear marker of high risk. It also exposes the limits of risk stratification with left ventricular ejection fraction. Higher EFs associate with less heart failure and less MACE, but having a higher EF did not confer a lower risk of death or CV death or arrhythmia. Global longitudinal strains seemed to underperform, but there was little data. Now, one criticism I hear when I reiterate how we as a field ignore the negative non-ischemic cardiomyopathy trials, especially Danish, is that these trials enrolled a lower risk and highly heterogeneous population. In fact, people rightly say that non-ischemic cardiomyopathy comes in many different varieties. This review shows that CMR ought to be a much better predictor than left ventricular ejection fraction. And perhaps if we enrolled patients with high LGE to ICD versus no ICD, we would likely show there's an ICD benefit. And in fact, the authors tell us that 2 such trials are ongoing. The German-led CMR ICD study and the Southampton-led British studies are open-label, government-funded studies randomizing patients with non-ischemic myopathy with an EF less than 35 and evidence of LGE on CMR to receive either a primary prevention ICD or optimal medical therapy alone. These trials will both look at all-cause mortality as the primary endpoint, and this is such good news. Now, there are aspects of the ICD story that have been quite ugly, right? The HRS caving to industry back in the day to allow non-EP docs to learn ICD implantation during weekend courses when the seminal trials came out. That was bad. Our resistance to find better risk stratification tools for up to 2 decades. That was bad. The general failure of key opinion leaders and guideline writers to emphasize the concept of competing risks of death, resulting in scores of frail elderly patients getting ICDs close to end of life. And the total failure to incorporate the negative Danish trial into guidelines. But I do like where we are going with this LGE-guided approach to ICD usage. It's a very much a positive thing. Patients with newly diagnosed non-ischemic cardiomyopathy often get a CMR. They probably ought to have CMR, though availability is not everywhere. Now, I say that patients ought to get CMR, but of course that statement could be studied empirically. Then we randomize LGE positive to LGE negative to ICDs or medical therapy. There is a chance that ICDs are going to prove helpful in patients with LGE, but there's also a chance that event rates will be too low and medicine's too good for the ICD to prove beneficial. I do think there's equipoise here. And I, for one, hope that the 2 ongoing trials enroll enough patients so that we don't have wide confidence intervals and we actually get an answer. And finally, kudos to the Swiss-led team who did this impressive meta-analysis. Okay, next topic is, when should PCI be used in chronic stable CAD? Now, we know for sure that PCI does not reduce MI or death in patients with stable coronary disease. We should therefore not do it to relieve fear of the doctor or patient. Sadly, I think that is actually why most PCI of stable disease is done, namely that these lesions look so gnarly. They do. I wouldn't want these lesions in my heart, or at least I wouldn't want to know about it. But let's say we lived in a world where everyone was enlightened and everyone used courage, Berry 2D, and ischemia trials. We would still have patients with an 80% coronary stenosis who has angina, real angina, not fatigue, Not funny shortness of breath while sitting down, not PVCs, not PAF, real angina. The patient in this perfect world is on a statin and an aspirin and has stopped smoking. Disease-modifying treatments are ongoing, but this patient simply cannot do much because of angina. And this is a pesky situation. This patient needs help. We now have two choices. You could maximize anginal medicines, nitrates, beta blockers, perhaps ranolazine. By the way, I had a patient with angina recently, and he thought I was a wizard because 30 milligrams of isosorbide vanquished it. Now, the other option is to say, screw these tablets, let's just do PCI and stent that lesion. The debate and choice came up because of the placebo-controlled Orbita-1 and Orbita-2 trials. Orbita-1 found that if you maximize anti-anginals, PCI adds no significant advantage over a placebo procedure. Orbita-2, however, took these patients with angina who were treated with anti-anginals and stopped the anti-anginals. Then patients were randomized to a PCI or placebo procedure, and in this case, PCI did have a placebo-resistant effect on quality of life and exercise time. Now, there's dueling essays in the journal Circ Outcomes, and they made different arguments. Christopher Rajkumar and Rasha Al-Lami argue that using PCI as it is in the guidelines, that is, for patients whose angina is not controlled on medications, selects for a scenario where PCI is least likely to benefit. That's an Orbita-1 situation. And this reason likely relates to the fact that patients with persistent symptoms on maximal medications likely have a non-ischemic cause of their symptoms. So fixing the obstruction is unlikely to have a physiologic effect, only a placebo effect. Rajkumar and Rasha Al-Lami argue, rightly, that both meds and PCI are strong anti-anginal agents, and whichever is used first seems to saturate all of the benefit. Since either a medicine first or a PCI first strategy should also be combined with disease-modifying treatments like statin, aspirins, not smoking, eating less donuts, etc., the choice could be discussed with patients and it could become a preference-sensitive decision. And I, of course, have no doubt that at Imperial College London there are great discussions wherein patients are made clear that PCI does not make them safer from death or MI, that PCI comes with a need for long-term antiplatelet therapy, that there will also be a metal cage in the artery, that PCI has procedural risks. But they would also explain to patients that if you have an elective procedure, it makes sense to take those risks when the odds are highest it would help, and that is when you do PCI up front. Now, Bill Bowden and Rafael De Caterina make the case in the dueling essays that Orbita trials do not justify the promotion of a PCI first strategy. They call the Orbita trials small, which is true, but not really. It's true in that they were smaller than outcomes trials like Courage, but Orbita trials enrolled enough patients to sort out a continuous outcome like treadmill exercise time. Bowden and De Caterina make 7 points. First, Orbita was already known, right? ACME had shown that plain old balloon angioplasty was better than tablets. Of course, ACME wasn't placebo-controlled. Number 2, they write, not all angina is due to obstructive disease. Thus, a PCI first strategy targeting epicardial disease may miss microvascular dysfunction. It's a good point. Third point they make, PCI first strategy exposes a lot of patients to procedural complications. Again, a good point. Fourth point, symptoms persisting after maximizing anti-anginal medicines should not always be considered a failure of therapy, but a failure to diagnose the proper problem, meaning that the target may not be the epicardial disease, but may a non-epicardial disease such as vasospastic angina or microvascular dysfunction. Fifth point, Bowden and De Caterina disagree with the sub-analyses of Orbita 2 that found that patients who had the most typical angina had greater PCI responses. The sixth point they make is that the ischemia trial found no penalty to deferring PCI. And they say that quality of life scores eventually, within a year or two, come together. And this is true, and it was also seen in Courage. At Courage, there were no quality of life differences at 3 years. And finally, they were very skeptical that shared decision-making will lead to truly shared decisions. Rather, they believe shared decision-making will be used to justify doing more PCI. And so Bowden and DiCaterina conclude that rather than decreeing the view that current guidelines set up PCI to fail, they strongly agree that a PCI-first strategy targeted largely to symptom control potentially diverts attention from years of progress in improving event-free survival with robust secondary prevention and lifestyle interventions. And if on the basis of the short-term outcomes of the Orbita trials in selected patients, clinicians choose to do PCI as the initial approach, they may become complacent or agnostic to the need for comprehensive secondary prevention and lifestyle interventions, and such a shift in management could in turn set up optimal medical therapy to fail with long-term detrimental consequences for our patients. So what's my take? If you're a neutral Martian working in an environment where PCI was not incentivized financially, and an environment where PCI wasn't considered super cool, which it is, I would side strongly with the Imperial College authors. Clearly, PCI provides a placebo-resistant effect in a medicine-free state. My siding with this argument not only assumes a Shangri-La type of state of affairs, but also that Imperial College-like people talk with patients. That patients truly understand that angina therapies seem to make no difference at 2 to 3 years, perhaps because of collateral vessels. That patients truly understand that PCI means taking an extra pill, perhaps forever, that is the antiplatelet, and that interrupting that antiplatelet confers a risk of stent thrombosis. That patients understand that PCI trades one disease for another, that is, coronary disease versus having a cage in the coronary arteries. I, for one, would probably choose tablets because I have a fear of having metal in my proximal LAD or RCA. But Bowden and DiCaterina have really good points. I am in 100% agreement with their skepticism regarding shared decision-making. This will fail miserably in the United States. I will bet you my Canon Aero road bike. In the U.S., the vast majority of patients will take PCI first because the doctor will favor that. I also agree with the idea that PCI first could lead to less use of disease-modifying therapies, but if that happened, that would be no fault of the Orbita team. The Orbita team clearly advocates for disease-modifying therapy. Finally, here is the thing. In many places in the U.S., we essentially have a PCI-first approach because so few patients with stable CAD who have PCI are A, having angina, or B, on proper antianginals. Therefore, if there was a guideline change that allowed PCI first after shared decision-making, it would have little effect on PCI use in stable CAD because the amount of patients leaving U.S. cath labs with high-grade stenoses without stents approaches 0. Now, the dueling essays are good. I'd go read them, and I think that Bram Nalamatthew is doing a really nice job with Circ Outcomes Journal. All right, final topic. It's a short one, but it really interests me. And this is about guideline-directed medical therapy underuse in HFrEF. Jack Heart Failure has a really nice research letter, first author Stephen Green from Duke, looking at physician-reported reasons for not initiating guideline-directed medical therapy in HFrEF. And they use data from something called the Adelphi Real-World Heart Failure Disease-Specific Program, which is a survey of cardiologists and primary clinicians in the U.S. And basically, the caregivers reported data for up to 5 consecutive patients with HFrEF, EF less than 40, who they saw in the outpatient clinic. For these patients who were not on full gas GDMT with the 4 classes of drugs, clinicians were asked to choose a primary reason for this from a list of multiple choice responses. And the research letter reported data from 86 doctors, 53 cardiologists, 33 PCPs, and they had 323 patients. These were 67-year-old patients, half on Medicare, a third with commercial insurance, and some with Medicaid or VA coverage. The median blood pressure was good at 126, median creatinine good at 1.1, K is 4.2. Okay, the results. Get this. 85% were not on full gas quadruple therapy. And for ARNI beta blocker, MRA, and SGLT2 inhibitor, the most common physician-reported reason for not initiating medication was that the patient was, quote, clinically stable and had adequate symptom control, end quote. And that occurred in 43 to 55% of instances for almost half the time. Patient preference was listed as 7 to 13%, out-of-pocket cost 2 to 14%, low blood pressure about 10%, kidney dysfunction anywhere from 0 to 9%, and previously proven intolerance about 1 to 9%. Comments. I can already hear the proponents. This is terrible. Bad doctors. Lazy doctors. We need a stick, not a carrot, to improve this. We need education. Well, let me respond to this by starting with the limitations of this paper. First, it's a small sample, and I have no idea what the Adelphi real-world heart failure disease-specific program is. It's also not clear if these patients were similar to the patients in the trials. The authors don't tell us about the median EFs, and I think that's a huge limitation because if I have a patient on, say, 3 drugs and has no symptoms and an EF of 39%, I might not push it. And I went back and looked at some of these trials. Take DAPA-HF. All the patients had class 2 or greater symptoms. The median ejection fraction in DAPA-HF was 31%. Look at RALS, the MRA study. 90% of patients had class 3 or 4 heart failure, and the mean EF was 25%. So I want to tell the HFrEF skulls to stand down a bit. I would want to know more about these patients. I don't see many patients like those in trials who are not on or who have not been tried on all 4 drug classes. But I also think the research letter is onto something important. Clinical inertia is real, and it's not always a bad thing. Regular doctors are in a constant struggle every single day to help patients maximize their health and minimize the impact of treatment or being a patient. Our aim is to help people, but also allow them to be people rather than patients. Every time a doctor walks into an exam room, he or she faces the Icarus analogy. You could be a dumb robot and keep pushing guidelines and forcing patients to spend more time doing medical things, and in the process, you could incur harm. You could fly too close to the sun. And perhaps if that happens, you lose the trust of the patient. Or you could get to a happy place where things are good enough, and the patient is happy. Perhaps the data extractors are not totally happy. And another factor in clinical medicine is that much of heart failure therapy is preference sensitive, isn't it? For patients who are maximizers, they are happy to titrate up medicines. They have their notebooks and spreadsheets, and they love their blood pressure cuff. And for them, fine, push on, do whatever you want, fly close to the sun. But lots of patients are minimizers. They don't have a blood pressure cuff, nor do they want one. No, they don't have an easy ride to the clinic. So for these patients, a little lisinopril and carvedilol that's well under the margin of risk is good enough. To me, this is not bad medicine. This is good medicine. You take this patient who's a minimizer and you say you have to take spironolactone, and then he gets painful breaths. He's not going to think much of you. Okay, I realize this is a pretty controversial topic. I come at it from the perspective of a practicing doctor, does this every day. You let me know how you feel. I'm happy to hear about it. Tell me how I'm wrong. So that's it for this week in cardiology from a rainy, windy Louisville, Kentucky. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.